Single Encounter Augmented Reality Guided Localization and Resection of Pulmonary Nodules. Case Application. First, the positioning tag was placed. After the computed tomography scan, the patient was transferred to the operating room. Segmentation was performed, and a three-dimensional reconstruction model of the lungs was obtained. Detectable magnets were positioned at the marker points. Following identification and linkage of the fiducial markers, puncture targeting was performed under lung inflation conditions. After the anesthesiologist performed lung recruitment, the surgeon completed the puncture and localization procedure. Based on the localization, the diseased lung tissue was precisely resected. How to use augmented reality guided localization for pulmonary nodule resection. Before localization, place the patient under general anesthesia and position the patient in the lateral decubitus position for surgery. Perform local skin disinfection over the approximate planned puncture area according to the model. Gaze at the auxiliary positioning markers on the patient, allowing registration to be completed automatically within 3 to 5 seconds. After registration, the virtual puncture path, puncture site, virtual nodule location, and puncture depth will display automatically. Determine the puncture depth according to the scale markings on the localization needle. Before puncture, ask the anesthesiologist to inflate the lung to 30 centimeters of water pressure and maintain it for 10 seconds. Once the lung inflation is completed and stable, perform the puncture immediately under the guidance of the virtual path. After completing the puncture, remove the augmented reality headset and immediately proceed with surgical skin preparation. Case application. In this case, the patient had a 1.1 centimeter mixed ground glass nodule in the right lower lobe and was scheduled to undergo resection of S9 and S10. After entry into the chest, the position of the localization needle and the presence of complications, such as bleeding, were assessed. After completion of dissection, sublobar resection was performed according to the position of the localization needle. The specimen was opened to examine the relationship between the pulmonary nodule and the localization needle. Intraoperative pathology indicated invasive adenocarcinoma of the right lower lobe. The hook wire was placed in the nodule.